Welcome back, and in case you're just joining us, this is The Nest. My name is Vivian Dagwa, and we are having a conversation on diabetes. Now, before we took that break, you were just explaining to us, you know, some of these fruits that maybe have a high concentration of sugar, and maybe which ones would you recommend? Okay. And for those of us who really love these sweet foods, what should we do?
You can still have them, but in moderation.
Yeah.
You know, when you've cut a watermelon and they come really big, and you've cut it into half and cut it into slices, if it's sitting right in front of you, it's very enticing, right? So you can have your 2 slices and put it back in the fridge or share with others. The secret I do, like if you're putting it on the table, don't leave it on the table. Then people will keep coming back for more.
Yeah.
So make sure you take it all around the room, so that by the time you're done, you're only left with the 1 piece. So you're also not tempted. If you are going to have the 2, then go and exercise. Burn off all that extra sugar. I need you to understand one of the problems people do is that they'll starve the whole night. I mean, you go to sleep like around 10, 11. You don't eat anything. So essentially your body processes it as you're in starvation mode. And supposing you're a busy working woman, you're told you have to be in the studio by 4 a.m. What do? You make a smoothie, right?
Yeah.
And you put in your watermelon, your banana, your mango, and then to make it healthy, your chia seeds and the simos. Now that's the healthy part. But then all this other is sugar. So what the body does is it recognizes that we don't know when we're going to get the next meal, so let's absorb up to 85% of that sugar. And then you come and you sit and you talk to Dr. Ngugi for hours, right? Have you broken down any of that sugar? So anything that is excess goes into the liver and it's stored as glycogen. Whatever is not stored as glycogen is converted into fats. And that's how people put on weight. That's why we stop those myths of meat is bad for you.
Yeah.
Because of cholesterol. We found excess sugar was actually contributing to your cholesterol more than. So we have to cut down on the carbs.
Okay.
So your healthy fruits. I know sweet melon is not essentially sweet, but the green melon is actually quite healthy. Your thorn melon, your apple. So what we say is, if you're going to eat like a bunch of grapes, just eat a fistful. The berries, raspberries, blueberries, for those who can afford, actually have a very high sugar content. If you're going to eat an orange, eat half an orange. Or if you're going to eat that orange, then I tell you, go and work out after that. The key is, are you going to burn all that excess sugar? So we tell you, eat fruits like a snack and not part of a meal.
Okay.
Let me explain. Supposing this is your plate, you had 1 chapati, you already had some vegetables, and you had perhaps some meat, okay? Or a slice of steak or 1 piece of chicken. Your chapati is already giving you enough calories as a carbohydrate. When you go and add a fruit, isn't that more carbohydrates?
It is.
Yes, so don't eat your fruits after your meal. Take a fruit as a snack. So you wake up, have your breakfast. At 10 o'clock, you can have a fruit as a snack. If you don't have time for that, then at 4 o'clock when you've just come home, have that snack, go for a walk, and then come and have dinner. So that you actually move, decentralize, avoid having fruits actually with the meal. I know we got spoiled because of buffets, that after you've had the meal, then now you're given fruits. And it's a Kenyan culture which we're really trying to say, you know, perhaps that is not a good idea. When you come for a wedding, how about serve us fruits, we eat, we dance when we invite the wedding party. And when we sit down, we
Then
eat
give
our
us the
meals.
meal.
Yes.
Okay.
So that let's work smart. I'm not going to change our culture. We are who we are because of our culture, but let's work around it. And the concept is, if you know you've had like a cheat meal of excess carbohydrates for breakfast or lunch, go easy on your dinner. You understand? And that makes a very big difference.
Okay.
Yeah.
All right. I want to wind up on the diet.
Yes.
So you mentioned about white and brown foods. You know, there's the white bread, white
Brown
ugali, brown ugali, you know, brown rice. What's the difference? And why is it better to have the brown one? Is it even better to have the brown one?
So a lot of our patients, when they were diagnosed to have diabetes, were told you should take brown ugali, brown rice, and that is why diabetes was a diagnosis of, you know what, it's like death is knocking because the food is bland, everything is terrible. But the concept is because it's unprocessed, it takes a longer time to digest from the stomach. So you feel full for a longer time. A mistake we didn't realize was it's about portions. So whether you eat white or brown ugali, you will still get the same glycemic load. So we say take your white rice, take your ugali, but what portion are you actually taking? If it's more than a fistful, then perhaps not. That is why we say you don't have to take the brown, but what we encourage you to do is take portions, the right portions. If you find yourself half your plate is ugali, half is vegetables, that is a wrong meal. A little bit of ugali, a little bit of proteins, and half of it be vegetables. That is a balanced diet.
Okay.
Yes.
All right. So let's get into now managing diabetes. What's the best way to go through managing diabetes? Say I've just been diagnosed with maybe type 1 or type 2 or whichever one of it. What's the best way to now, where do I start from there?
Okay. So I'll break it down into type 1 and type 2. For type 1, you know you don't have any insulin reserve. So the first important thing is, what are you eating? So we'll sit down with a dietitian and work it out. Because it's a condition where you have no insulin, everything you eat is converted into glucose, which is what the cells use for energy. And the insulin is pushing this glucose into the cell. So we teach you what is called carb counting, carbohydrate counting, and we tell you this apple is equivalent to 10 grams, which is equivalent to 2 units. And we sit and we teach you how to be able to calculate how much insulin you need based on your diet. So the most key thing for both type 1 and type 2 is your diet. We're not quick to talk about exercise in type 1, because if you exercise and you've injected yourself and you have not eaten well, your sugar will go low. So first thing is, let's talk diet. First, let's talk about your diagnosis. Have you accepted it? What are the implications? We'll screen for complications. If you don't have any complications of the eye and the heart and the kidney and the nerves, then we'll start you on insulin. Now, because your body only produces insulin when there's a glucose load, we will give you injections as you eat, with breakfast, with lunch, and with dinner. But because we are human and we are prone to snacking, then we'll give you another injection, which is a long-acting insulin. So you end up having 4 injections, because that is how your body produces insulin in the body. And so you'll find a lot of our patients under the age of 18 are on 4 injections a day. It's a better way of controlling your sugars compared to just morning and evening. On the other hand, there are people who are truck drivers and have diabetes. What would you do? Then we'd give you insulin in the morning and the evening, but the type of insulin we give you can be able to last 12 hours. So if you inject at 6 in the morning, then you have to inject at 6 p.m. and that takes you till the next morning so that you can inject again. So diet is key there, and then you introduce insulin. Then we tell you, supposing you want to go and work out, so we'll tell you, eat your banana, the one that you love, and then you work out. You'll be able to remove the excess glucose by burning off the extra calories. Type 2, on the other hand, is a bit more complicated. You have some degree of insulin, but now we base it on your HbA1c. If you have no complications, we'll give you a chance with the diet and the exercise concurrently. But we give you a drug to try and help the body produce more insulin to cater. So we have about 8 classes of drugs. And so I say, if I picked one like yours, I wouldn't give you one that helps with weight loss, because you certainly don't need it. On the other hand, there are the newer drugs which I would give, which would, one, work on my kidney, on the heart, and also help me lose weight. And so that is how we tailor it, and we give you tablets, depending on how your sugar control is. And we target and we tell you, if you wake up in the morning before you eat, we want your sugars between 5 and 7. But then after you eat, it shouldn't go above 8. Because anything above that, when you have excess glucose, it goes into your eyes, it causes cataracts. It goes to your heart, it makes it enlarged. So you're prone to having unstable rhythms and heart failure. Goes to your kidney, causes leakage of proteins, and that's how you end up on dialysis. And it affects your nerves. So you start getting tingling sensation of your hands, your feet, you get burning sensation, you end up peeing at night, or you wake up in the middle of the night with diarrhea. But depending on what complication you have, now we have targeted treatment. If you are diabetic, you have a heart condition, we'll give you a group of drugs called the gliflozins, like EMPA, gliflozin, and DAPA, because that means we are targeting other complications other than just diabetes. If we find you're overweight, we'll give you something as basic as metformin, because it helps reduce the resistance. Remember, in type 2, it was more of you have insulin, but it's not functioning very well. So to reduce this resistance, we give you metformin and another drug. So it's no one particular drug that will be given to everyone. We tailor it according to you. But for type 2, one thing you need to understand is that by the time we've diagnosed you, 50% of the cells that produce insulin are gone. And every year, 5% are lost. So we are looking at, in 20 years, you will end up on insulin. It doesn't mean you failed, it's a progressive disease. And so what we essentially end up doing is putting you on insulin in the long term if you've had diabetes for more than 20-25 years. Okay? One of the other things you do for type 1, you know, this constant injection is very frustrating. So now we've come up with new technology that's amazing. It's called an insulin pump, where you put the needle just here over your belly, and it stays under the skin, and then you have a monitor called a continuous glucose monitor. So the way it is, you have to have a smartphone with Bluetooth enabled, and all it does is it connects to this machine. This machine actually records your sugar every 5 minutes. So when you're feeling dizzy, tap your phone, it will tell you your sugar is 3.1, so you need to eat. So what the type 1s are doing is you've got the glucose pump, you've got the monitor, and you want to eat. And we've taught you an apple is 10 grams, a chapati is 20 grams, so inject 5 units. So you'll just press buttons, 5 units is delivered, and you're good to go. So life isn't as bad. So it's what we call an artificial pancreas for the ones who need insulin.
Oh, thank God for technology.
I know, it's expensive, and we are hoping with time the government realizes this is important and then can help us buy this for our type 1s. You know, we have programs where we're now giving insulin for free, but up to the age of 25. But what happens to that type 1 who is now 26 years old? You have to fend for yourself. So those are the things, like, we're pushing towards moving them to make insulin free for all. Yes.
All right. So now, you know, there's a report on the prevalence of diabetes, and there's one that had mentioned that the prevalence of types of diabetes was almost 2 times higher in urban areas compared to the rural areas. Maybe what could be the reason why in urban areas we have more people getting diabetes compared to the rural areas?
So it's several factors, but one thing is the prevalence in Kenya is grossly underreported. They say it's 3.3% as per our last step survey, and I understand Ministry of Health is currently undergoing a process where they want to check the new prevalence. We know for sure, because people don't go for annual checkups, that is actually not being captured. Now the reason why you have a higher prevalence is sitting right in front of you. You have your television. Your children are constantly on their iPads, on their phones, their television, instead of running around. So we are not active. One of the other things is genetically, if you're obese, your children are predisposed to be obese, and these are the ones who will end up developing diabetes later on in life. Then it's actually, fast food is actually cheaper in this country than the vegetables, and we actually checked. Chips mwitu is like 10 shillings. I learned. See the little, like this fistful of chips in a paper bag is 10 shillings and very tasty. What do they add? Salt and then sauce, and then it's fried in a lot of oil. Okay, just think about that. That's just carbohydrates. If you tell that mother to go and buy the unga for ugali and then buy the vegetables, then the cooking oil, and then also the paraffin for cooking. How much is that? So that's also an imbalance. Another thing is we don't have good food labels in Kenya. It should actually outline this product contains this amount of sugar. They label it as carbohydrates. When was the last time you actually went and actually looked at a food label? One of the things we are pushing, like Ministry of Health talk about, is as you go to the supermarket, it should have a clear label. This has sugar. This has fat. This has how much protein, so that you understand the implications. If you go and look at certain products, butter and all that, it actually outlines how much salt. So we are working towards now trying to reduce that. So one is the lack of exercise. Number two is the type of diet. And then our medical conditions are then now just being passed on. But it's also just basic things. We spend so much time. Like now, one of the pushes we have in school is every school has to have a playground. Have you seen a mushrooming of school, but they have only one play area, and you have 5 streams in a class, and then you have up to standard 8. So how are you going to? So one of the things we say is work with your spaces. Let this group go to play at 9 to 10, another one 10 to 10:30, another one, so that there is more activity. Yes. Then other things that people don't do. How do you spend your weekend? Watch movies, chilling, Netflix relaxing, and chill, right? Yes, so what we are saying is get out. We only do marathons when we are talking about, let's talk about diabetes, why can't we do it as a regular activity? Karura is open for all, and you only pay 100 shillings. Why not spend time with your family? Instead of in the fast food, go to Karura Forest. Or if you still want that, after that, go for a jog. People say they can't exercise because they're in the city. But if you will find the people from low resource, what do? They walk to work and they come back to work. What do? I leave my house, enter the car, go to the hospital, see the patient, sit down, enter my car and come back. Where have I walked? I have not exercised. So we are even encouraging companies now to build gyms. And you know what they do? If they can't build a gym, get gym membership. Then I'll tell you, I will pay half for you. And if you don't go a certain number of times, it comes out of your paycheck. Wouldn't you actually encourage people to exercise? So one is more of lack of exercise, more of sedentary lifestyle. We are focused more on media, unfortunately, in media. But this is how we disseminate information. But we can still work on it. In offices, instead of standing, there are some offices now where the desk, you can put your laptop there and then cycle as you exercise, and it actually tells you how many calories you have burnt. Or just walk. At the end of the day, just let it be a basic exercise that you can be able to replicate daily, and that makes a very big difference. Yes.
The prevalence also shows that it's higher in men than women. Is there an explanation to that?
Yes. So number one, it's 2 points. Genetically, they are predisposed. Then number two is also behavior. Socially, men only come to hospital when they are dying, isn't it? When they're absolutely sick, they don't like to know. But also in terms of metabolism, in terms of like testosterone and all that, your metabolism is actually slower compared to women. In one instance, you've noticed men lose weight easily compared to women, and they also put on easily. But we find also in terms of catabolism, the rate is actually slower than women. So they can be able to ingest large amounts, okay, but only if you're able to exercise commensurate. So if you are the kind which we advise, with a very healthy appetite, you also need to have a healthy exercise regimen. But for men, it's mainly because of the hormone testosterone. Women, what is actually protective is our estrogen. That helps us. But for men, they only have the testosterone. We have both estrogen and progesterone. So at any point in time, that helps us with our metabolism. They also have the thyroid hormone and the growth hormone, but it's not as active as the women. And then also their health-seeking behavior is not as well pronounced as in women.
Okay.
Yes.
All right. So When we talk about diabetes, of course, we've touched on all the things that we've gotten to mention. And of course, it's not a death sentence. There are ways to manage it. There are ways to just go about your normal day-to-day life having it.
Yes.
So maybe if we can talk about the treatment options. I know that in the middle of the conversation, there are some that you've mentioned.
Yes.
If we can just now just look at the treatment options available for someone who has diabetes.
Just one thing before we get there. You know, it's actually possible to not reverse, but push diabetes into remission. What does that mean? You're found to be diabetic, we start you on medication, we work on a low carbohydrate diet and exercise. You can actually reverse it to the point where if you do your tests, your sugars always read normal. And what we found is we can push you into remission as per the direct study about 8 to 10 years before it comes back. Okay? So the typical prescription would be diet and then exercise. If you have type 1, it is just purely insulin. So depending on the type, if you're purely type 1, then we'll give you a short-acting insulin 3 times a day and 1 long-acting insulin. Or a premix insulin. I don't want to mention names because of what's in the market. Then you have type 2. Now type 2, other than diet and exercise, you have one of the basic drugs, which is metformin, to reduce your insulin resistance. And that will give even to women who have polycystic ovaries, because of it reduces the insulin resistance and prevents you from developing diabetes. Then you have another group of drugs called sulfonylureas. Very good because they tell the pancreas, please secrete excess insulin. So you have drugs like gliclazide and glibenclamide. Problem with glibenclamide, commonly sold as no-gluc, it can cause low sugars for up to 3 days, even after stopping it. So we are trying to phase it out of the market and then introduce other drugs like your glimepiride and gliclazide, because those ones control your sugars better. Then you have another class of drugs called SGLT2 inhibitors, sodium glucose like transporter 2 inhibitors. Those drugs came into the market and changed how diabetes is. If you have heart failure and you're not diabetic, you can take that drug because it's actually been found to reverse the negative effects of, say, pressure and diabetes on the heart and actually restore function, or at least retard the progression of your disease. Similar, if you have kidney disease, we give you these SGLT2 inhibitors. Examples of those, they roll off the tongue. Dapagliflozin and empagliflozin. Those are very good because they, and sotagliflozin, they can actually reverse the process of early chronic kidney disease and prevent it from progressing. So by the time someone is getting to dialysis, it's bought you an extra 20 to 30 years and prevented you from going to hospital. Then there are the newer agents, the new kids on the block called GLP-1 analogs, like your Ozempic, which I'm sure you've had. It's an amazing drug because, well, it's bad, it's being abused for obesity, but it's not being prescribed correctly. You know, when you stop that drug, all the weight that you lose actually bounces back even almost double. We tell you, we'll teach you about diet and exercise. Then when we give you, it will control your sugar, it will help your heart, and it will help your kidney. But it also has that additional benefit of losing up to 20 kgs or 20% of your weight loss. And we give it in a staggered fashion because it comes as both tablets and injectables. What's there in the market is the injectables. It comes at 0.25 milligrams. You start once a week and you take that for 4 weeks. Then you graduate to 0.5 and then 1 and then 1.7. But even after you've reached your target, we reduce the dose to the minimal dose that you are on and maintain for another 6 months to ensure you don't regain that weight. You'll find if you are on insulin, we added that drug, actually your doses come down. Because the number one problem for our patients with type 2 diabetes is control of pressure, control of their obesity, cholesterol. So if you're able to get a drug that helps with all these 3 conditions, that is why we give you that particular brand of drugs. The other drugs that are there in the market have such bad GI side effects we don't normally prescribe. But another one that's very good is called TZDs, the Kikuyu in me, I apologize. Thiazolidinediones. Things like pioglitazone and rosiglitazone, they're good because they help people with a fatty liver. We found If you are obese and you're diabetic and you have excess fat stores in your liver, what actually happens is it can cause your liver to fail. So to prevent liver failure, we give you this medication. So we have quite a number of drugs. Just sit with your doctor and they'll explain how to. But one thing I add, just because I prescribe for you a particular drug does not mean you give your sister or your cousin or your chama mate the medication.
Yeah.
Please tell them to come and see the doctor. They'll advise which is the right medication for them.
Okay, and as we get to wind up, probably would you advise a diabetic patient to join maybe a support group?
Yes.
And the importance of such groups?
So we have quite a number of societies that look at the patient advocates, like the Kenya Defeat Diabetes Association and Diabetes Management Information. They work predominantly with patients, and we tell them it's a chronic condition. It's difficult when you know you're the only, especially if you're the only child struggling with a family where everyone else is okay. So we encourage, and you'll find most of the hospitals have their own patient support groups, but there's always information out there in the news, like from KDD and DMI, and even KDSG, on which patient support group to join, because they will help you when your sugars are low, when the sugars are high, and they encourage you. I think one of the most important things with a chronic condition, if I come and I tell you you need insulin for the rest of your life, it's depressing. So we deal also with the mental health problems. We're seeing a lot of the diabetes patients going into depression, and that is alleviated by the patient support group. So it's we work together. You have the diabetologist, nutritionist, food specialist, exercise physiologist, the patient in front of you, and the support of the family. And then all the other specialists depending on your complications.
All right, our time is up, but maybe I'll give you 30 seconds to give us your parting shot. Just 30 seconds.
So first, thank you. But my parting shot would be, take a chance today. Go and have your blood sugar tested. It could actually make a difference and decide what your future is going to be. If you screen for diabetes today, it means you have, it's one less person who gets an amputation, one less person needing a transplant, a kidney transplant, and does not need dialysis, one less person admitted in hospital, and all those resources could be pulled back to be able to help us come and develop new ways of managing diabetes. So I'm turning back to you and giving you a challenge. Test your sugar today. It will help you live longer. And thank you for such a forum.
Thank you so much for coming to the show, and thank you for enlightening us as well on this topic, that is diabetes. This is where we get to end today's show. Thank you so much to each and every one of you who has been tuned in. Remember, if there's anything you need to take from this discussion, is your responsibility to go for medical checkups. Make it a culture that you go for medical checkups at least annually. My name is Vivian Ndagwa. Do enjoy the rest of your viewing. Goodbye.
Diabetes.